Number one is stop bleeding. You can't optimally resuscitate, and you will waste your resuscitation fluid if you don't stop bleeding. And so the original description, which was written in between combat casualties, number one is stop bleeding, and I think number 9 is stop bleeding. And there's a whole bunch of stuff talking about resuscitation in between, but it's stopping bleeding. Use all your adjuncts, all of them, to stop bleeding.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care. All right, well, welcome everybody. Thanks for joining. Welcome to Frontline Surgery. I'm Joshua Dilday, one of the Army trauma surgeons. I'm joined by my illustrious co-moderator here. Jeff, you want to introduce yourself?
And I'm Jeff Conner, also an Army trauma surgeon.
In this series, we help prepare early career military surgeons for the realities of deployed trauma care. We share key insights from those who have been there. But today's episode focuses on something that is foundationally important to deployed military trauma care, and even now on the civilian side as well, damage control resuscitation, or DCR for short. It's one of the most critical tools for managing the severely injured combat casualty. Today's guest is none other than an expert in the field, one who started this whole process by leading the way in research, implementation, advocacy, Dr. John Holcomb. Dr. John Holcomb is a trauma surgeon with multiple deployments under his belt, well known in the military and civilian world for his research across a vast array of trauma-specific problems, advocacy issues, and new developments that have shaped the way we take care of trauma patients now. And so, Dr. Holcomb, thank you so much for joining us. We like to start every podcast episode with a scenario and kind of put you in the realm. So, Jeff, get us started with a scenario and let's get Dr. Holcomb's expertise.
Here we go. So let's start with this. It's 3 a.m., 3 o'clock in the morning at a Roll 2 forward operating base in a mountainous region of Eastern Europe. Your team receives a 9-line for 2 U.S. soldiers injured by an ambush IED blast during a nighttime convoy. The first casualty arrives hypotensive, tachycardic, and soaked in blood with bilateral, what appears to be lower extremity traumatic amputations. There's no access to component therapy, and your cold stored whole blood supply is already half depleted from an earlier case. You have a small surgical team, limited blood products, and the golden hour, unfortunately, has long passed.
Dr. Holcomb, this sounds like an extremely scary scenario, but I know you've lived through this multiple times. So when you hear this, what goes through your mind of planning as soon as that patient rolls through the door?
Yeah. So, Josh and Jeff, great. It's great to be here. That's a tough case. That's a tough scenario. Unfortunately, one that's very real. And several things. Number one, preparation. You have to know that your blood supply is low before these people get here. You have to be aware of that. And so, in your mind during the day, you're talking to your team, the rest of the team. Go, what are we going to do tonight when somebody rolls in? The preparation is key. People that have bilateral low extremity amputations require a lot of blood. So our tourniquet's in place, number one, when that guy rolls through the door, because that's going to conserve your blood supply. Number two, what about the second patient? That is the second patient. So in the scenario you presented and in real life, these patients don't come in all at the same time. They come in usually in waves. Now the problem with waiting to know what happens with a second patient is he may never come in. He may be dead. He may be minimally injured. You don't know. So all you know is the guy in front of you. And the scenario you paint is one that I personally faced several times. And you don't do it well the first time and you get better the second. That's just the reality of being deployed. My advice in this situation is call early for your walking blood bank. You said that's a small team in an isolated location. You may not have availability of a walking blood bank, or you may have already used it up the day before. So all of these factors go into play in taking care of this one casualty that's probably going to take 6 to 10 units of fresh whole blood to definitively stop bleeding. And then, of course, you get even harder when you go into real triage scenarios. Are you going to use your dwindling supply of blood on this one soldier?
Yeah, that's really great insights. Can you tell us, for the listeners, just some of the basics of damage control resuscitation? What do we mean when we're in a resource constrained environment and we have somebody like this come in? What's the first thing that comes to your mind when you hear damage control resuscitation?
Yeah, so when you go look at the original description of damage control resuscitation, number one is stop bleeding, right? Number one is stop bleeding. You can't optimally resuscitate, and you will waste your resuscitation fluid, blood, if you don't stop bleeding. And so the original description, which was written in between combat casualties, by the way, running back and forth to the computer, number one is stop bleeding, and I think number 9 is stop bleeding. And there's a whole bunch of stuff talking about resuscitation in between, but it's stopping bleeding. Use all your adjuncts, all of them, to stop bleeding. And then, of course, balanced resuscitation, whether that's with components or whole blood, low titer whole blood, stored cold whole blood, walking blood bank, and minimize to no crystalloid. Because if you give crystalloid, you'll actually increase bleeding and increase coagulopathy and increase your blood use. But it's real. I'm just going to emphasize it starts with stopping bleeding. It ends with stopping bleeding, and all that other resuscitation stuff is in between.
So there's a term that's thrown around, hear it sometimes in the civilian sector as well, but permissive hypotension. How is that incorporated into damage control resuscitation?
Yeah, Jeff, it's a great question. And been some mystery about this. It's actually, in my mind, pretty easy. Permissive hypotensive resuscitation really was defined very clearly in World War II. Starts in World War One, very clearly in World War II, where whole blood was the resuscitation fluid of choice. In fact, it was the only fluid really for sick patients in the hospital. And so it comes from the observation of the guys that took care of hundreds of thousands of casualties in 6 months with the same injury over and over and over again. And if you raise the blood pressure above a systolic pressure of 90, that you're going to actually waste your blood products and increase your blood loss before you have definitive control of hemorrhage. It was very clear. We then repeated those in animal studies and showed the same thing. And by the way, in the old days, we used to do open aortas, ruptured aneurysms. And it was very clear from the aneurysm aorta data that the anesthesiologist and the vascular surgeons were very clear that if you raise the blood pressure above a systolic pressure of 90, you would pop the clot while you were fixing that big vessel. And so they kept the pressure below that. It's exactly the same. I am a firm believer in this hypotensive permissive resuscitation with blood products based upon the experience in World War II and subsequently.
Now, I actually have to go off script here because we actually had this conversation this morning within our group. But you said something interesting that I actually didn't know is, I know when I think permissive hypotensive, I think of crystalloid based resuscitation. But you mentioned World War I and World War II, and you were talking about, kind of where we are now is what's old is new again with whole blood resuscitation.
Yeah.
And so you're saying even with whole blood resuscitation, popping the clot is a risk if the blood systolic gets over 90.
Yeah, Josh, it's an important point. And the reason I said it the way I did is just because of this. Really, it's a misnomer. People haven't read history. The hypotensive resuscitation, people quote Maddox's article, who was a senior author. By the way, the first author was an Army ER doctor.
Excellent.
In my Journal of Medicine paper. And if you read that paper carefully, the references go back to World War I and World War II, Cannon and Beecher. Cannon, World War I, Beecher, and World War II. That's where it comes from. That was not a new thought. What was new was applying it in the civilian world, with crystalloid in that time with that paper. But the historical references and the scientific basis is based upon blood product resuscitation from World War I and World War II in combat casualties. Exactly what we're talking about today. History is important.
That's great. That's great. So I've got a question or kind of the next kind of point here. So this may be self-explanatory, but military civilian environments are totally different on some level. When we're so used to having everything at our fingertips, from imaging to massive amounts of blood, what are some of the things when we look at a military setting or a combat setting? What are some of the things that stand out to you that are most different when it comes to providing damage control resuscitation or getting these casualties compared to the civilian environment?
Yeah, there's a couple things, and they come. There's kind of philosophical, conceptual, and then practical, right? I think that broad-based experience is really important. So for our young surgeons to go out to take their experience from the civilian world and translate it into the military deployed setting, small unit teams out in in an austere environment. It's not easy because you have to learn how to crawl, walk, run before you sprint. To me, the sprint is out in a deployed setting, taking care of the casualties we were talking about earlier. That's a sprint. That's not easy to do. But it's easier if you learn how to do all of these things in a really busy military and or civilian or mil-civ, whatever you want, but busy trauma center. We're exposed to these injuries, albeit different mechanisms. So you have to know how to, you have to be able to sprint. To do that, you have to crawl, walk, run, in my opinion. When you're deployed, and it hits everybody, the first time you see a guy with 100 holds, that knocks you back a little bit. Because you don't really see that in the civilian world. You might see a guy with 1 hold, 2 holds, 3 holds, 4 holds, but not 100 from an IED, from the IED fragments. And no matter who you are, it knocks you back when the first time you see it, because now you have to figure out what's underneath those holes and are they injured, from the top of his head to the tip of his toes. Combine that with a burn injury, and those patients are difficult. Yeah, so broad-based experience, neurosurgery, orthopedics, vascular, neck, chest, abdomen, pelvis, extremities, all those things. And you look around when you're in a deployed setting, you go, hey, where are all those people? And they're not there, right? If you're lucky, you're with an orthopod. It's you and an orthopod. My first time I was deployed for real, me and the orthopod pulled out a book in the operating room to figure out how to put an X-fix on a little girl's jaw. So pediatric surgery using an orthopod, and we put an X-fix on her mandible. We'd never done that before. There's all sorts of new things that you will do. The best way to figure out how to do that is to, have as broad-based experience as you can back in our civilian world, and then be mentally prepared for doing things that you've never seen or done before.
And coming back to the resuscitation piece of this, can you speak to maybe not totally encompassing all the different roles of care, broadly blood availability downrange? Can you count on it? The walking blood bank is also a thing, but what are you typically looking for, or what can you expect when you're downrange?
Yeah, and this is where I think the young surgeon needs to really work with the older surgeons and the majors and the colonels. It just has to be available, and it can be. For the whole team out there, from the commander, the log guy, the nurses, the helicopter pilots, everybody's got to understand, everybody has to understand that wherever there is a medical capability, there needs to be blood available. I mean, it's a petrified fact. And this is where we as leaders in the deployed trauma system must pound on the table to make sure it's available. And you got to make sure it's available before the injuries happen. Because once the injuries happen, you can't make stuff up. It has to be in place.
And let me clarify, because I just want to make sure I'm hearing right. So we're talking about blood being a necessity for all of that. What blood are we talking about? Because I've read recently that for the military surgeons, when they see this warm, fresh, whole blood being given to a trauma patient, it's like a religious experience, was the quotation that was used recently. Is that exactly? It may have been coming from someone on this call. Is that really that much of a difference? Is that the difference in military? Is it always fresh, warm, whole blood? What about low titer? How much are we relying on this blood product? Why does it have to be available that quickly, no matter what circumstance?
I mean, it doesn't have to be, but it improves outcome, right? And so if our goal is to have the best possible outcomes on the battlefield for, the combatants, then we need blood as far forward as we have medical people. Now, that's a different kind of blood. There are different kind of blood products, Josh, as you've articulated. Dried plasmas are really important. Dried plasma was available to medics in World War II. In fact, the resuscitation paradigm in World War II was dried plasma pre-hospital and whole blood in the hospital. That's where we need to get back to today. There's not enough whole blood, low titer, or fresh whole blood to put pre-hospital in it to keep it cold and all the cold chain storage, and then you have to warm. But we can't put dried plasma pre-hospital like the IDF has done recently. And 11 other countries around the world have dried plasma available. Dried plasma needs to be a push by all of our senior military leaders to be in the hands of every medic at every place. I mean, it's actually pretty simple. Every medic, every place, right? Every battalion aid station. And then as soon as you get back where there's cold chain storage available, we should have either low titer or whole blood or the walking blood bank, some combination. That will improve optimal outcomes.
And you mentioned this interesting phrase, which I'm going to keep in my back pocket, but I think it was excellent. The majors and the colonels working together. And for those majors or triceps repetition of rank alone, for those early surgeons who are deploying within their first or second deployment, or even some who just haven't deployed in a while or haven't seen the combat zone in a while, what are some of those key pitfalls that you would say these mistakes cannot be made in a damage control resuscitation environment?
Yeah, my first deployment was as a young major within a year.
Sure.
I deployed on exercise. The first real world was within 18 months of graduating. General surgery residency, by the way, not a fellowship. And, I fell on a group of people that had thought about this quite a bit. Number one is take care of the local nationals, right? So there's this idea that we must, not take care of local nationals to keep everything ready. And that's wrong. If you take care of local nationals, not only does it build goodwill, but it also exercises your system. So you exercise your system by logistics, medical, supply, evacuation, etc. Everything gets exercised by taking care of patients, no matter where you are. Right? And you'll find out if you have blood or not, right? You'll find out if you have suture. You'll find out if the X-ray machine works. Whatever. All of the inside the tent and outside the tent with stuff we talked about get exercised by taking care of local nationals. Then you'll be ready, and I speak from experience on this. Then you'll be ready when the onesies and twosies and the mass cal happens. You will be ready. Your system will be ready. The commander will be ready. Everybody will be ready, from the general officer all the way down to private. That's probably the most important thing outside of the details of how to care for.
That I was not expecting for you to mention that. But that's a phenomenal point. So basically, a program of consistent readiness. A well-oiled machine gathers no rust. A rolling stone gathers no moss. Whatever that is, I had not thought about that way. And you bring up an excellent point.
I think it's been we've talked about this in other forum, but I think and this is where, and I talk about the colonels and the young majors working together. This is the senior medical people, the junior medical people, and the line commander, whoever is responsible for the area of operations, needs to understand the value of exercising the medical system before the U.S. casualties, the mass casualties, whatever come in. And if you sit around and wait, then you're not ready.
What about when we're in that scenario? So what about, let's say we've been ready, we've got a good rapport with the local nationals, we've seen our system moving, but now I'm in that scenario that you just described. I know I'm going to exhaust a lot of my blood product, but I know I'm not experienced. What are things that you want me to hear in the back of my mind from the voice of John Holcomb saying, make sure this is obtained, make sure this mistake is not done? What would you say from the clinical application that I have to make sure that I don't do?
Yeah, well, Josh, I think we've talked about this, right? So you're going to see things that you've never seen before. I do think you just have to be mentally prepared for that. We used to have books, right? And a long time ago. Now you have your phone, which you could download a book on. I would recommend downloading that book, whatever books that have good pictures, because you're going to need them in the operating room. Plan ahead for the eventualities, just like it was when you're a resident and you're laying there at 2 a.m. going, what is this going to happen that I have to take care of by myself? It's the same feeling. Run through with your team. What are you going to do with a penetrating wound to the head? What are you going to do? Do I have the stuff to put an X-fix on? What are you going to do for the pregnant patient that comes in? The female patient, all these different scenarios. And do I have the equipment and the knowledge? Have I thought about what to do? All these injuries that in the level 1 trauma center back home, you call the expert. And now you're the expert. I tell you, the thing that scared me the most, it wasn't the heads or the ortho or whatever, it was the eyes. And, eye injuries. And, what are you going to do for eye injuries? We're kind of prepared for other things, but honestly, the eye injury was the most scary for me.
So coming back, we've talked a lot about damage control resuscitation. We've talked about permissive hypotension, number 1, stopping bleeding, and number 10, stopping bleeding, having blood product available. Are there any other adjuncts, whether it's TXA, calcium, that you incorporate into your algorithm or your kind of protocol for managing these patients?
Yeah, that's a good question. I'll just go back to Josh, your previous question. You must pound on the table to have those things available that you find you don't need as you exercise it. And you know what? If you exercise it, the hospital command, whoever the commanders are in your chain, the young majors, they almost always will be responsive, not to PowerPoints, but to real scenarios, real problems. They will be, or they should go away. And then, Jeff, the TXA is important. If you look at the data, its actually impact is minimal. I think we use it a lot. I think the impact in brain injury patients is greater than hemorrhagic shock. Honestly, the thing that I personally have used as an adjunct more often than not is good tourniquets. In the operating room, you can use the wider tourniquets. Really helpful for the extremity bleeding, so that you don't lose 3 liters of blood when you don't need to. Vascular repair is the same thing. And then really good hemostatic dressings for these big wounds, really good hemostatic dressings to include, and I have no conflict, but the Everest dressing, which is fibrinogen and thrombin, I put that on holes in the superior vena cava and on the aorta.
Wow.
Last week, we put it on an SMA and SMV injury. It'll stop holes in major vessels.
Now, how easy is that to have downrange, or is that something that we need to bring with us or request from our leadership?
I retired in 2008, so I don't know what's in your sets, kits, and outfits anymore. But I will tell you that if I was deploying, I would make sure it's available one way or the other. And it is available in your NTFs. So it's in the system and it has an NSN. Get your supply guy to order it and make it available. It'll stop bleeding in major vessels. It's more expensive, it's better, and then mix and match with the other hemostatic dressings that are out there. They work.
And that segues into the last point we really want to make sure that we address with you is in preparation for this deployment. We're coming up, let's say we're early in our career, we've got a deployment coming up, a couple months. I've got the books, I'm recalling my training. I've probably reached out to you and other mentors. What are some things I can be doing now to prepare so that when I'm in that scenario, I'm not leaning on my errors, but I'm gaining your expertise and the expertise of others so that I'm better prepared than I would be?
Yeah, Josh, it's a good question. And, the young major may not have a lot of power to do things, so to speak, right? But hopefully that FST cash commander, old words, right? But level 2, level 3 commander is making sure the team is prepared. It's gone through just, some of the available just-in-time training if they're not at a permanently assigned location in a MilSIP partnership or in a busy, TF in comments. So I think the team training is really important as well. Getting to know your teammates and getting to know their strengths and weaknesses. Everybody's got strengths and weaknesses. And if you're going to deploy as a team, make sure your team is working together, before you deploy to get that opportunity.
That seems to be a consistent theme. If I'm taking away 2 themes from what I've heard about damage control resuscitation, stop the bleeding, stop it early, give blood, rehearse with your team. Yes. I think that's leadership 101. And honestly, I wasn't expecting you to focus as much on the rehearsal and stay ready element. And yet we hear that in every other aspect. So why would it not be? And that's a key component to mass casualty leadership scenarios and crisis management. So of course it would be. And that's why we had you on. We were so honored that you gave us that point of, yes, it's not just about give blood and give blood early, but your team has to even know. Would you say some of these scenarios, your team almost has to be on autopilot when these scenarios come in?
Everybody needs to function relatively independently.
Interesting.
Especially the smaller teams, right? Yeah, and the only way to do that is to prepare. You can prepare notionally, go through scenarios, right? And then you can prepare by taking care of local nationals. That's the best way.
That sums it up. That's golden. Jeff, I think this was phenomenal. We had a legend being able to speak to us about his expertise, both clinically, leadership philosophy, tenets of damage control resuscitation. I don't think we could have gotten any better conversation than that. What do you think?
Yeah, I'll echo Josh. Dr. Holcomb, thank you so much for joining us. Really gave us a good insight into what, as early career trauma surgeons in the Army, what we can expect or plan for at least. And really appreciate you being here with us today.
Listen, guys, it's my honor to be here, and you guys will do great when you get out and about, no question.
Thank you so much. For the listeners, we hope today's discussion gave some practical tools. Obviously, you got to hear a phenomenal discussion with Dr. Holcomb, both leadership philosophy, damage control resuscitation, how to prepare, tips and pitfalls. That's what we do on Frontline Surgery, Mastering Trauma Care. This is exactly what we do on the podcast, and we're so excited that you listened. Dr. Holcomb, thank you so much for being our honored guest today, and we look forward to many more discussions, and I'm sure we'll have you back on soon. On behalf of Jeff and myself, thanks so much for listening. We'll see you next time.
Take care, guys.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield-ready knowledge. Until then, stay ready.